In this video, we're going to talk about disorders of electrolytes. We're going to focus a lot on potassium. In part one, we established that sodium was the primary cation in the extracellular fluid, while chloride was the primary anion. Phosphorus is also an important electrolyte in the extracellular fluid. Although most of our phosphorus is found in our bones, 14% of it is in the extracellular fluid. Remember that we need phosphorus for glucose, fat, protein metabolism, for red blood cell, white blood cell, and platelet function, and it also serves as an acid-base buffer. I briefly introduced this slide in part one. It is really important for you to remember that potassium is the most plentiful intracellular cation. Because of its high concentration in the cell, it helps to maintain intracellular osmolarity. Potassium is also important for resting membrane potentials, and potassium ions can be exchanged for hydrogen ions when blood pH is too acidic. The kidneys finally control potassium levels. In fact, if someone has renal failure and they're on dialysis, we expect to see their serum potassium rise between dialysis treatments. And those patients have to avoid high potassium foods. Calcium is important also to nerve and muscle cells. There's actually a very small amount of calcium within the cell, and when extra calcium leaks in, then it can activate cells. And in the case of cardiac pacemaker cells, this can cause the cells to fire. Calcium is regulated by the parathyroid hormone, and when that hormone is released, then calcium reabsorption from bone is increased, again pulling more calcium into the serum. That ends up being good for the cells, but ultimately bad for the bones. The third intracellular electrolyte you need to remember is magnesium. Magnesium is an important component in enzymatic reactions to make ATP, DNA, and messenger RNA. Magnesium tends to block potassium's exit from cardiac cells, and that affects the repolarization. It also competes with calcium, and it actually sets on some calcium receptors and can serve as a smooth muscle relaxant. This is an important figure that depicts the shift and the interchange between potassium, sodium, and hydrogen. Recall our discussion of aldosterone. Remember that aldosterone is released by the activation of the sodium-potassium pump. So the kidney releases aldosterone, and aldosterone, whoops, I did not want that slide to advance, sorry. It releases aldosterone, which promotes the retention or the movement of potassium to the intracellular space, and sodium moves to the extracellular space. So you can see in the presence of aldosterone, potassium shifts in, sodium shifts out. Also, epinephrine, which is released by the central nervous system during fight or flight, causes some shifts in an activation of the ATPase pump and sodium to be shifted out. And finally, this last diagram is depicting the potassium-hydrogen exchanger. And in this situation, hydrogen and potassium move in opposite directions. So when serum hydrogen is high, as with acidosis, then potassium leaves the cell, and so that the hydrogen can change places. So that means that during periods of acidosis, serum potassium levels would be elevated. One of the most important things to remember about blood potassium levels is the effect of potassium on resting potentials of cells. Hyperkalemia generally makes neurons and muscles more excitable, while hypokalemia makes them less excitable. Cardiac dysrhythmias can happen from both hyper and hypokalemia. And they happen to be the most serious effects we can have. That's related to the potassium's effects on repolarization. Hypokalemia is caused by either inadequate intake or excessive losses of potassium. Most diuretic therapy causes potassium to be lost through the kidneys. So as we increase diuresis, we tend to wash out potassium with all of that extra urine. Another common cause of hypokalemia is vomiting and diarrhea. We can also have the potassium shifts like we talked about on the prior slide, where intracellular potassium shifts out into the extracellular space in exchange for other ions. Remember that we'll talk more about alkalosis and about pH disorders in the next presentation. But know that alkalosis can cause a shift of potassium from extracellular to intracellular, and therefore lowering serum potassium. Nurses need to be able to recognize the symptoms of hypokalemia. Remember that potassium helps control resting potentials of nerves and muscles. The primary symptoms, therefore, end up being nervous system manifestations, including confusion, paresthesia, and paralysis. The muscle symptoms, muscle weakness, cramps, tenderness, and the most serious symptom, which is cardiac dysrhythmia. Hyperkalemia, on the other hand, is caused by excessive intake of potassium. It's pretty hard to get too much potassium just in your diet, but we commonly give patients potassium supplements, and we can overshoot the mark and create hyperkalemia. And this could be oral supplements, but probably more dangerous would be giving IV potassium, which we do frequently. But when we give potassium IV, we have to give it very, very slowly because a rapid infusion could cause a cardiac arrest. that would be like an immediate hyperkalemia and effects associated with that. Potassium, as we've talked about, lives in the intracellular compartment. However, in the case of severe tissue trauma, like major crush injuries, severe burns, and extreme exercise, we can have a lot of intracellular potassium released into the vascular space, into the serum, and cause hyperkalemia. Sometimes the kidneys just don't work well enough and we can't eliminate potassium. And again, we talked about hyperkalemia in the situation of renal failure. And if you look at these symptoms of hyperkalemia, they're very similar to the symptoms of hypokalemia in terms of cardiac dysrhythmias, nerve and muscle symptoms. But people with hyperkalemia may also experience nausea, vomiting, and diarrhea. And that concludes this discussion of electrolyte imbalances. And next we're going to talk about acid-base balance.